will in fact document this. So, welcome everybody. My name is John Crouch. I'm Digital Education Manager for Dentsply Sirona for Endo and actually a few other business units, and have done this for quite some time. They almost always go great. They do always go great when Sergio's the speaker, thankfully. So, anyway, we'll get started here. Thank you for participating on the polls while I'm talking. If you want to keep doing that, I know Sergio's glancing at those while we introduce here. Um, Sergio Kuttler, I'm not going to do a huge intro because I think most people signed up because they do know him. He's going to tell you a little bit about what he's doing when he starts his presentation anyway, but he's going to give us some great knowledge. It is important I disclose, Sergio is one of our designers and is involved with some of the products that are going to be shown in his presentation. So it's important in an education standpoint to definitely disclose that. However, he, along with many of our designers, I've always noticed, pay far more attention to sharing education than they do about any certain product. So I think you're going to get some great tips and not feel this is a commercial endeavor. We're just happy to use a platform like this to put him in more places. As you'll notice, it's one-way audio at the moment. We'll probably keep it that way when we have larger crowds. I think everybody appreciates it's usually better if we don't have too many microphones on or noise that we have to deal with. So it'll be one way, but there'll always be something on screen. At the moment, it's a chat pod over here, which shows people's names and their comments. When we switch to Sergio's presentation, you'll see a very similar box, but it will be called Q&A. And very important for you to know that is private. So your comments will not show to the crowd, nor will your name be seen to the crowd. So if you have important questions or comments you want to send in, those will only be seen by myself and Sergio, and we will deal with those generically, probably at the very end. So that, again, it's meant to free you up. There's no dumb questions. And, anything that the reason you came, the reason we're doing this is so that you can get your questions answered. So please feel free to do that. Other than that, I'm going to soon hand it over to Sergio, and I'll be stepping off the camera and the mic and just kind of in the background, hoping for things to go well. And I'll be watching for comments if anybody has anything. Sergio, let's go ahead. If you want to take a last glance, I think you've been watching the polls, but let's go ahead and move over to the place where you can share your presentation. I'll stay here with you until we make sure that's up and running, and then I'll step off. And thanks everybody for attending.
Okay.
Great.
I want to say, okay, you tell me what?
Yes, sir. Carry on.
Okay. First and foremost, I want to thank everybody for taking time out of your busy practices from home, from dinner, from some of you, and to be here with us today. And as John said before, this cannot be possible without the help of Den Supply, and specifically with John. You do all this for all of us, and we thank you very, 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 very much. Okay, lots of material to share. So let's start with the introduction, okay? Noise. Okay, so let's talk about the golden era of reciprocating instrumentation. And I welcome all of you today, July 25th, okay? I give you warm welcomes from the International Dental Institute Forever Learning here in Florida, where Dr. George Bruder and I are co-founders of this institute in a very beautiful location after retiring, quote unquote, or giving up education as a per se in an university environment. George and I have founded the International Endodontic Institute Forever Learning. And if you are coming through the United States or taking a cruise from Florida, please let us know. We will love to have you in our institute. So, we cannot talk about nickel titanium. We don't remember. His soul may rest in peace, because unfortunately, Dr. Walia passed away very recently. Without his contribution, none of us would be using nickel titanium. And if we are going to talk about nickel titanium, let's talk about a little bit of the history. The first generation of nickel titanium starts in 1991. It has a passive radial end, fixed tapers, cross section, and at that time were systems that they use for, or systems that you require to use 18 instruments to prepare a root canal. That was the first generation of rotary instrumentations, nickel titanium. The second comes about 10 years later, and now we have active cutting edges, changing tapers, still one cross section, and from 4 to 18 instrument systems. And active cutting edges, it's interesting because now the file will engage into the canal wall and cut dentin instead of scraping the dentin. And we are going to be hearing more and more every day minimal invasive endodontics to produce smaller preparations inside the root canal, but this is not new. It was in 2001, three great endodontists, John West, Pierre Mastou, and Cliff Rodel, with ProTaper started the changing tapers. They were thinking already in preparing a more conservative preparation inside the root canal. The third generation comes 6 years later with the really refining, the size of refining metals. It was a big change. Now, instead of having regular nickel titanium, and there were two companies at that time, Cybron Endo, and then Supply, they came up with a different nickel titanium. And through their research, that nickel titanium will last longer in cyclic fatigue. But it was until 2010 that really, I believe, the endodontic world has changed. 8 of us had the opportunity to work for Dentsply, Sirona, and VDW to create two incredible instruments, reciprocating instruments. One was Way One, and the other one was Reciproc. So this team really changed what we do today. And in 2010, we still have an active file, changing tapers, changing cross sections. Now we have an instrument that had past tense, two different cross sections from D1 to D9 and from the D8 and from the D9 to D16. It was different. We are going to talk about that later on. But it has a unique movement. Now it's not a 360 degrees rotation. It's a reciprocation movement. And the most important one is that also we are able to create that convenience form, that particular shape with only one instrument per se. We are going to go step by step on this. Then in 2011, 12, 14, and 15, we still change it because really the pace that changes in endodontics we're going through, and we still have an active file, changing tapers, but the most important is the metallurgy, blue, gold, and black. I define technology as the train that is coming to the station. If we don't hop up in the train and the train leaves without us, it's going to be very difficult for us to catch up to that train for the benefit of our patients. And I know that sometimes I make very strong statements, and one of those is, if you're still using just a regular nickel titanium, my dear colleagues, I'm sorry to tell you that your train has left the station. We must use, with new metallurgy, these incredible instruments available in the market. Now, what is the future? The future is awesome. I'm pretty sure eventually we are not going to use metals, we are going to use polymers. I don't know when. I know that very good researchers, academicians are doing research in non-nickel titanium metals. So that metallurgy probably will change. But the most important is the nanotechnologies. That is really changing our world. We are going to have a glimpse of that in a second. But what else? Really, the future is very bright for endodontics. In nanotechnologies, this individual, Dr. Anil Kishen, changed my life when I met him in Phuket, Thailand, in one of the meetings. And all his work, I've been following Anil since then, and now since he's in Canada. But this book will give you just a little glimpse of what is coming in endodontics, in nanotechnologies. Canal preparation using only one nickel titanium rotary instrument, preliminary observations, actually was Hassan Yared who started steering the pot, who started really gave us excitement on how to use a rotary instrument, but on a reciprocation movement. He was using an F2 ProTaper. So it is actually Hassan who started it really to give us all this excitement. But let's go a little bit into the history of reciprocation. Many of you were not born in 1958 when Dr. Roger Blanc in France, he invented the gyromatic. And this instrument was going 90 degrees clockwise, 90 degrees counterclockwise. After that, the second generation of reciprocation instrument comes about in 1992, the M4 contriangle from Kerr. This contriangle will reciprocate the instrument, but only 30 degrees clockwise, 30 degrees counterclockwise only. And I question why they changed from 90 and why they changed for 30. Then the third generation of reciprocating instrument comes about in 2000, which is the safe-siders. Those, I'm pretty sure, I don't know if this system has been available in the places where you are, but it's a file that it's a flat file, it's not a round file. But again, this instrument would just only reciprocate 30 degrees both ways. The fourth generation of reciprocation instrument starts then in 2010. Now we have the Telos instrument from also then 30 degrees, and we have Weiwan, 150 degrees, 30 degrees clockwise, 150 degrees counterclockwise. And I have asked the other companies why the different degrees from 90 to 30 and know what we have. And I have never got an answer from them. But if you are going to question why 100 degrees counterclockwise and 30 degrees clockwise, because it's 120. 3 movements of the file, it's a full circle. And the qualities and the peculiarities of the file makes it a very, very, very good instrument, as we are going to discuss later on. But once again, 30 and 150 is 120. Three movements is 1 full circle. Then the fifth generation of reciprocation instrument comes about in 2013, the motor elements, which is the twisted adaptive file. The file is exactly the same. The file has not changed at all. It's the same. But what it changed is the motor. It will go in a rotary motion, 360 degrees, and when the twisted file adaptive senses that torsional strength, the motor will start reciprocating to go 50 degrees clockwise, 370 degrees counterclockwise. And also, the next generation, the 6th generation of reciprocation is the Genius file from also then now it goes at 90 degrees clockwise, 30 degrees counterclockwise. So as you can see, reciprocation, it's not new. Now, let's continue here. What is the future? And it's very interesting to see that since 2010, Dentsply Sirona and VDW have brought to the market these 2 files, Weiwan and Reciproc. And since then, and this is only one slide that I'm going to show you, all these companies have copied what we have created in 2010, actually in 2008 when we start working. And why? What is the reason that, and this is only one slide, I can assure you, I have 3 other slides with almost 40 names of companies reproducing, because we have brought the best 2 files in the market for reciprocation instrumentation. So, since I was a student at the University of Southern California in 1982, I got very, very interested in understanding how an instrument works. What is the peculiarity, why it works this way or cuts this wall versus the other wall? And I have been very, very blessed in my endodontic career in doing research with all these files that you are looking at, with the endodontic Q methodology, as well very recently with micro CT, and now using a nano CT. So we need to understand how these instruments really works inside the root canal. We know that we can prepare a root canal, we can with any instrument, hand instrumentation, rotary instrumentation, reciprocation instrumentation, stainless steel, nickel titanium, we can do that. But the risk and efficiency of these instruments varies dramatically from one instrument to another, even sometimes in the same systems or from manufacturer to manufacturer. So when we have an instrument and we are going to work with it, we need to understand the risk and the efficiency of these instruments. It was in 2010 in Athens, Greece. I had the honor of presenting the science of Weiwan. That's when Weiwan was launched. After that, after 2010, the eight of us, we were hearing how colleagues were discussing, and we hear them. What do they like? What do they dislike of way one? And then supply divided the team, and this is the team that has created way one gold. So, and it is interesting that I'm showing you this because when way one actually was launched into the market, it was in 2010. And then we started changing the instrument in 2012. And we worked with Way One Gold in Valais, Switzerland, and we tried many different cross sections, different tips, even sometimes different alloys. And up to the date, almost, it was in 2015 in Germany, in Cologne, Germany, at the very famous IDS meeting that Way One Gold was launched. And it's Julian Weber baby to go to the IDS, and he introduced Way One Gold since 2015. The material that you're going to see now, I don't do it by myself. It is impossible for someone to do so much work. I really have to introduce you to my team, my research team, that we collaborate very close each other. My three right hands, George, Jose, and Rigoberto, and my left hand, which is closest to my heart, is my wife, Carmen. It's actually all of us, and especially them, who really works hard on what I'm going to show you. You can see that only one name has an asterisk, and that asterisk is after my name, because that asterisk means that I have a financial gain of presenting the science of this instrument. So this is Way One Gold. This is how it is. It's a pre-sterilized package. Until today, I checked that even yesterday, we have only six mechanized systems that they come pre-sterilized. The rest of them, every time that we open a package, we must sterilize that instrument. It's a single instrument. Most of the time, I would say 90-95% of the time, you need only one single instrument to prepare that convenience form that it will allow us for a deep irrigation and 3D filling. Single use, all instruments, I don't care if it is hand, stainless steel, or whatever. All endodontic instruments should be used only one time. I know that many of you probably right now will be raising your eyebrows. Sergio, it's crazy, but it has been very well established by the literature. Endodontic instruments cannot be sterilized 100%. And by using these instruments, it's a simplified root canal treatment. And I say simplified because these instruments have made us realize how much we love endo, because it is not so complicated and it's easy to perform nowadays root canal treatment. Let's talk about the improvements, what we had before and what we have today. The need to find the ideal instrument for a general dentist and also for endodontists have created tremendous amount of interest within the scientific community, clinicians, and manufacturers for one single reason. We need to develop instruments that will clean and shape more efficiently with less effort. That's the purpose every time that we create a new instrument. They have to be better the way they perform, and with less effort for us. Let's compare Way One versus Way One Gold. Instruments per se, that has not changed. Usage application is a cram-down motorized reciprocation movement. That has not changed from one file to another. Usage format, it is a power applied reciprocating motor. And this has to be with the same motor of the company. It will take me several hours to explain about motors, but every company has in their own motors embedded in the firmware and software how to drive that file, all the parameters. It is impossible, it's not an impossible, but you will run into procedural errors if you are using a motor from one manufacturer versus the files that you are using. We need to be cognizant that every time that we use a file, we need to use the motors from that same manufacturer, because it's embedded in that motor how to really use that instrument. Angles and cycles per minute, that has not changed. Instrument sizes have changed. We used to have 3, now we have 4 instruments. They have changed also the sizes. The instrument tapers have changed. We have made way one goal a more conservative file to prepare more conservative to preserve more tooth structure, more dentin. Instrument tip, we have changed it. Instead of being a bullet tip or modified guiding tip, now we have a semi-active tip that it will start scouting the canal in an easier form, so that will prevent too much apical pressure. Cutting surfaces, we used to have in the cross section 3 blades, and now we have 4 blades with 2 points of that blade touching every 200 microns the canal wall. So that means that the file will stay centered in the long axis of the canal. The helical angles and pitch, the helical angles has been changed. Now they are constant, it used to be variable, and the pitch still variable. The rake angle has not changed, is the way that the blade engages into the canal wall and cuts the dentin. The transverse cross section, we used to have 2, now we have only 1, which is a parallelogram with 85 degrees angle. I'm going to show you all these with scanning electron microscope and research in a minute. We have changed the wire. It's not an M wire anymore, it's a gold wire, and the gold wire is post-cut, which I'm going to explain. The package still sterilized, and the sizes remains 21 in length, 25 and 31 millimeters. So this is the small, this is the primary, this is the medium, and this is the large. So why is important to understand what part of the canal and the sizes? If I have, for example, 20 millimeters length, if I'm going to do a molar, and we know that the crown of that molar is between 9, 10, or even sometimes 11 millimeters in length, we are actually only preparing 10 millimeters. And it's important to us to understand every single millimeter, the width of that file, so we'll understand how conservative preparation we're going to be preparing. This is the small, this is the primary, this is the medium, and this is the large. Okay, and please do not put large files in mesial canals. And we have to be very cognizant of the root canal anatomy. Where can we use these large instruments? So in sizes and tapers, okay, what is the rationale? How do we came up about these dimensions of the files? It's not that we did little numbers on a piece of paper, we put it in a cup, we shake the cup, and then we were taking these numbers and say, oh, let's create a file with this dimension. No, it has a rationale why. I don't know if you have read this book. I know that this book has been translated in many, many, many languages, but this is a great book because Dr. Spencer Johnson has a statement in his book that applies to every day what we do in our practice and with our career. Once you change what you believe, you are going to change what you do. If you don't change in your philosophy, in your principles, unfortunately, we will never change what we do. So, root canal therapy, I'm still talking about sizes and tapers, has 2 dimensions, the vertical dimension and the horizontal dimension. The vertical dimension from your reference point, how far you are going to prepare the root canal. And if I can go around and ask you, we will spend probably hours with different philosophies, what we were taught at school, what we were taught when we were in a graduate program, or probably what do we do today. But we need to understand. It was in 1955, Dr. Sergio Kuttler. He was my dad, okay? I never wrote this article. I was 5 months old, so I couldn't write it. I know that some people think that I wrote this article, but no. Where he established the CDC junction, canal, dentin, cement. And he said in this younger group, it should be prepared to 0.5, but not to the radiographic apex. My father never said that in the article. He says to the major diameter. Some people have the philosophy that says, oh, we will prepare to the apical constriction. The apical constriction could be above that CDC junction, canal, dentin, cement, because pulp pathology. Or also this calcification or narrowing could be at the very below, at the very end, below the CDC junction. So we need to really establish that CDC junction. Let me show you. You're going to say, well, these are nice drawings. Let me show you with micro CT some of our studies. This is the apical constriction, okay, which you can see it's above the CDC junction right here. and this is the major diameter. We need to understand that we need to go to the CDC junction as much as possible to confine our instrumentation and our obturation. In elderly population, it is farther away. That CDC junction travels from the major diameter because the apposition of cementum in the patient's life. We need to understand that. And nobody can perform root canal therapy without an apex locator. This is a must. And if I ask you, well, who was the very first one who started using or reported? Many of you are going to say, yes, was this the Japanese Tsunada? No, it's not. It was Dr. Kuttler. And none of everybody who's listening to this webinar was born in 1918. That's the first note in National Journal National Dental Association that later on became the American Dental Association Journal. In 1918, we were told already to use apex locators. So on the vertical dimension, and then we need to understand that once we ascertain that length with an apex locator, it is a must that we need to check with a radiograph. The horizontal dimension, how far, which one is going to be the last instrument that you are going to be using at working length? And this is the most controversial one. This is the most controversial one. I can start talking about Grossman. He's the very first one who said 3 instruments from the very first one that binds. And I can go through all this literature, which, by the way, if you require, if you need these articles and etc., please don't hesitate to email me. I will be very happy to send it to you in a PDF format. But we need to understand how far we are going to enlarge the canal. Rationale for file selection. In our institute, before we start any course, or like today, I was seeing what makes you decide to choose a system, to purchase a system to use with your patients. And we have all these answers, but the most popular answer is this. Many practitioners will choose a system because of money instead of because of size. And that's something that it really breaks my heart. I understand in some economies, but we are really compromising sometimes patient quality by using some other instruments. Minimum preparation of the root canal space. As I said before, you're going to be hearing, I rather use a different term as Dr. George Bruder talks about, dentin preservation platform instead of minimal invasive endodontics. Should be dentin preservation platform. If I show you this tooth and an x-ray, these are our micro CT studies, you will say, that's not a problem to treat this tooth. These mesial roots doesn't look that complicated. This is what we would look on a root canal x-ray. And if I said, well, take 20 degrees angulation of the x-ray, still, but now I'm able to see a concavity. Let me show you the deep concavity that this tooth had. So it truly depends the system that we use, that we are going to preserve for years to come this tooth in the patient's mouth, or we are going to shorten the life of this tooth. Now, when we take an x-ray, what we see is from black line to black line. And actually, we think that the canals are centered in the root. They're never centered. The distance between the canal wall and the PDL really varies dramatically in every single tooth, and it's different. Look at this mesial roots of this other model. As I said, I've been gaining weight because I travel a lot and I have incredible food in all these incredible countries that I visit. This root looks as fat as me. And it could say, it's easy to do a root canal here. But once again, look at the concavity of this root. And it depends the system that you're going to use, that you're going to be, I would say, successful, or you will not run into procedural errors. If we have teeth like this, what are you going to use? A regular nickel titanium? Moreover, we have to be careful, because if we don't know how to manage these type of curvatures, we must advise the patient that we are going to fill with metal. That means that the instrument will unfortunately separate. But we have to be conscious of these curvatures, and some of them are very severe. So which instrument should I use? It was my good friend Steve Buchanan, the one who talked about that many endodontists and general dentists are still working to see in that x-ray that fully body looked, because that will be associated with better treatment results. But no, actually, we need to have long-term prognosis. So we'll be really realizing how much we are weakening root tooth structure. That's very, very interesting. Look at this tooth. It looks great, without any doubt, in 2010. Okay, that was given to me by Dr. Bob Rhoda. But a year before this tooth was treated, and when it was extracted in 11, look at the crack. It looked very full, very, very good endo. This was at Nova Scotia University, where I used to be the Associate Dean for Advanced Education Programs for 15 years. PROS brings this case to the endo department because the endo has to be redone. It has been leakage because of the crown. So the student retreated this tooth in 2000. Patient comes back in 2007 and says, I have a pimple in my gum. And look at the crown, it's beautiful. Look at the root canal, it's beautiful. But what? What happened? By doing the retreatment, too much tooth structure was removed, so this tooth was scrapped. Same here with a patient. They were doing some root canals with some instruments, and according to those directions for use of those instruments, they said that you need to enlarge to a 55 in all of the canals. That's the minimum that you have to do. The student went ahead. You can see the bone where it is right now. And then when these tooth start developing a problem, then we realize what happened to this tooth, because they have weakened that root structure by preparing large canals. And the last one, immediately by looking at these x-rays, we can assume that the foreca, which is an endo lesion, is not a period lesion, and the apical area will really heal because it has a very good and large preparation. And actually, this alveolar socket healed faster when we extracted the tooth, because this is what happened. You can see how this tooth was cracked because the sizes of these preparations. So, in our instrumentation, until today, there is no stainless steel, no nickel titanium rotary system, neither a reciprocating system that will kill bacteria. Metal does not kill bacteria. What kills bacteria? We know it's irrigation. Patient came to Nova just for a checkup. You can see some bridging mouth. And by statistics, if this patient would have his entire dentition and it requires a root canal, over a 60% probability that it will require in a multi-rooted tooth. If it has 28, it goes to like flipping a coin, 50-50%. Nowadays, of recent economics and conditions of many, many countries, including the United States, over 80% of the root canal, and worldwide, you can look into the Health World Organization, worldwide, over 80% of the root canals are done by whom? By general dentists. And general dentists have to understand, and I know that you do, how far we should enlarge this canal. This is the rationale of the small file. It was Robert Lowe that says the following, that microorganisms will travel in a different area, middle, coronal, middle, and apical, inside the dentinal tubes. And he said that in the apical region, they will only travel 60 micron, which is file number 6. If we are using a 25 file, which is 250 microns, we completely have eliminated those microorganisms and will allow a small instrument like this, okay, to be able to irrigate the canals. Now, I know, and even my philosophy many, many years ago, especially when I graduated from the University of Southern California, was to prepare to a minimum of 40, which was 400 microns. This is too much. We are removing too much tooth structure with it. Look at this scanning electron microscope session. This is 25 microns. So imagine the bacteria traveling that far. Look how clean these canals look by just virtue of preparing with a number small of way1, which is a 20 at the tip with a taper of 7 in the first 3 millimeters. And we are going to talk about how we were achieving all this irrigation, which is with a new system that is going to come out by the end of the year that I'm going to mention. So I don't care what file do you use. What I truly care is for you to understand, if you're using an 04 taper, 06 taper, or whatever taper, in every single millimeter that you're working, how much tooth structure you are removing or how much tooth structure you are leaving behind. Why is the rationale of that we advocate small instruments. We did a research study. It took us a couple of years. It was presented at the AAE. And basically, we were looking for the middle third canal in lower roots of mesial molars. Very fast, 200 mesial roots, photograph, buccolingual, mesial distal, radiograph of the same working length established. So we were certain that we have 400 canals, 200 mesial buccals, 200 mesial buccals. We scanned them with the micro CT, data analysis with VG Studio Max, and this is the statistical analysis, which was in an S format to see the difference between apical, middle, and coronal. These are only 12 of the teeth that you're looking. This is the photograph from distal to mesial. These are the x-rays of the same teeth. We see two canals, two canals, two canals. But my dear colleagues, you know very well, better than me, this is the true anatomy of these teeth. So how are we going to be able to achieve success with such complex anatomy we have? This is on the upper left. This is looking coronal apically. Below that, lower left is mesial distal. Upper right is buccolingual. And this is how we measure, once again, by nature, that CDC junction. And let me show you, let me give you some preliminary results. 72% of the samples, 144 roots of the 200, had a middle third canal. 92% of that middle third canal initiate and finishes in the apical area. There is no microscope, there is no loops that we can see this. And over 50% of the apical CDC measurements in the middle third canal was the same or sometimes even larger than the area, than the size of the mesiobuccal or mesiolingual canal. So every time that we are going to have, I'm sorry that it looks so jumpy, it is a very sharp, but at any rate, this is the tooth. If we are going to have a molar, you have to remember that this is the anatomy that we are going to have. We are not going to have only two little tubes, one in mesial and then in another one in lingual. And that photo was the one that was the cover of Pathways of the Pulp. That was the 11th edition. And I'm giving you a good news. By April of next year, my dear colleagues, the new Pathways of the Pulp is coming with the 12th edition. Stay tuned because it has an incredible materials inside. It's coming very soon. So to conclude the sizes of the apical area, let me just blow the lower right and do the rendering. And these are the measurements that we have. Here it is. We have mesiodistal, which is from on top of the screen to the bottom, 150 microns, buccolingual, 140 microns. So why this is our CDC junction? My question is, why do you want to enlarge to a 30, 35, and 40? There is no reason why. And I don't want to bore you with all this research material, but for you to understand that if this is the CDC junction and it's only 120 microns and 140 microns, why do you want to enlarge to 300, 350, and 400 microns? There is no need to do that. There is no need to do that. So, 5 dimensions. After a thorough literature review of root canal anatomy in different languages. Actually, it was in 5 different languages that we got articles. And after all the micro CT studies that we have done at NOVA, if you're preparing to a 25, is plenty enough at working length to promote a very good irrigation, a deep irrigation, and to fill the canals 3-dimensionally. If the canal is tight, you want to prepare to a number 20, but achieve a good irrigation and a good instrumentation, it's fine with me. For those of you that have the philosophy to enlarge the canal, that's why we have created the 35 and even the 45 file to be able to use. Okay? Now, way one goal. This is the system. This is an irrigation needle. This is a 25 gauge irrigation needle. We took the cap, put it into the SEM. This is a 28 side vented. This is a 30 side vented. If you're using a way one gold primer, 25, it gives you plenty enough. Look at the x-ray. This is a side vented 30 gauge irrigation needle with a rubber stop. You can go all the way to working length and the needle will still loose. Please never, ever, ever lodge the needle inside the canal and press the embolon of the syringe because we are going to create a sodium hypochlorite accident. But you can see that every time that way one gold penetrates inside the canal, we can achieve a deeper and deeper irrigation without any problem. Here we have another cases of mine. Look how deep I can penetrate. This is Rigoberto. It's almost at working length. You have wave one goal in one of the canals and a 30 gauge irrigation side venting needle in the other canal. This is what it's coming. It's going to be a new device that has several functions. One of them is to irrigate and produce some light. So the solutions that we use with in SciAct Corporation with nano bubbles will react and it will really clean the canal. All this work has been done by this incredible researcher, this incredible brain, Dr. Anil Kishen. These are the studies of Anil Kishen. These are the controls. And here we have, you can see some bacteria inside the dentinal tubules. Okay, here the same, a different section of the SEM. And when we use this, we have achieved, and we reduce the log of bacteria up to 5 or 6. Never ever achieved that in endodontic therapy. Look at here the canals, okay, without any bacteria. It's something that we are very, very excited with Anil. This is the coronal. This is the coronal at 1000, at 500, and look at the entire coronal section. That is how clean it is. And I can go into the middle canal at 1000, middle canal at 1000, apical canal at 1000, and here you have the entire canal at 37. Look how clean that canal is. So Anil keeps doing this incredible research, activating these solutions with a very small laser, which is powerful enough to activate and promote this incredible shear strength on the canal walls that it will eliminate bacteria and smear layer. So I don't want to bore you with this incredible, but we are very, very excited. We are in the final process of bringing this to market. But it's Anil Kishen who's really doing all this research. This is the latest one of Anil, June last month. It's incredible. So that was in terms of sizes and tapers. Metallurgy have changed. Now it is a regular nickel titanium that after the file has been grinded, then it goes into a thermal treatment. And that's what makes it gold. And that thermal treatment will provide this instrument with properties that no other instrument or regular titanium instrument will have. So on the cross section, we used to have 2 different cross sections. Now we have only one, which is a parallelogram with 85 degrees in its corners. The 2 opposing corners are in constant touch with the canal wall every 200 microns, so the file will stay centered in the long axis of the canal. This is the tip. As you can see, it's not around it. It starts cutting very, very near the tip. It starts actually scouting, and it's easier to advance this instrument inside the canal instead of making too much apical pressure. It's like it will walk by itself. I know that many of you have used wave 1 and wave 1 goal, and you're able to appreciate these differences. This is the tip of the instrument, wave 1 goal. Now the motor. This is the way that the motor will work. As I said before, we must use a motor that has the software and firmware to drive these files. Can you do a root canal with a different brand motor? Yes, probably you can, without any doubt. Are you going to be able to encounter some procedural errors? Yes, you will, because it needs not only the speed, the degrees from left to right, but also it needs the torque from clockwise to counterclockwise, and also it needs the speed to move this file clockwise to counterclockwise, and you cannot change those in the motors that you have. It is the motors from Dent Supply that they are embedded in their firmware and software, as I said before, how to drive. This is the latest one, which to me, in my own opinion, is the best motor that they have really created with a very small head. You can turn the head. I mean, it's really, really neat. I will need almost half a day to talk about that. But it was Dr. Henry Kim in Busan, Korea, who established scientifically that you must use a motor from the same manufacturer to be able to achieve a good outcomes. So let's talk about rotary reciprocation. What should I do? If I do rotary, once the file starts rotating, remember we go to stress, strain, And then when we have a taper lock, we go in what it's called plastic deformation. And after plastic deformation, the file will go into what? Plastic limit. That's why files will separate. That's why files will separate. If we do reciprocation movement, there is not enough time for the instrument to go from plastic deformation to plastic limit. The file will just come back. And that's why many parts of the world, many universities in the United States, from 64 dental schools, now approximately 39, they are using solely in the undergraduate program way one goal is because instrument separation is non-existent. And we have got into their statistics. So let me talk about research before I go very briefly in how do we use this instrument. Cyclic fatigue, this is the jig that it was established years ago, and everybody follows this jig. I'm such against this jig because it will only touch two different points. But at any rate, with a similar type of jig, we did the research study in Madrid, Spain, of comparing way one versus way one goal. In cyclic fatigue, this is the methodology that we did. This is the instrument machine, the motor, etc. Here it is. And I'm showing the very last seconds until instrument failure. And to achieve to that instrument failure, it took approximately 5 minutes and 9 seconds. Nobody stays 5 minutes, 9 seconds inside the root canal. Then on the flexibility, we took, this is the methodology, how much force do we need to take that file 24 millimeters inside the jig. I will give you the results very soon. Also in the torsional strength, this is the methodology. This is the machine that you clamp the file 3 millimeters and then you start, in this case, rotating anti-clockwise until the instrument will separate, and then the machine will calculate. And also the bending test. In the bending test, we have two results: the force of flexure, and I'm sorry, we have two readings here. I'm going to show you here. This is how much force do you need to bend, force of bend, and then the residual angle that it goes the file to. Okay. Now, here we have the results: way one versus way one goal. In the cyclic fatigue, way one goal was 17.5% superior as way one. Way one goal in the flexibility was an incredible 48.5% more flexible than way one. Way one goal in the torsional strength was 53.5% better than way one. In the bending, the force of flexion, it was an incredible 87.5% better. And in the residual angle was 147%. Why way one goal is better than way one? For everything that I have said before, is because of the, mainly because of the metallurgy, because of the cross section, because of the tip and the tapers. So that's why way one goal is far superior than way one. Now, I'm going to give you the surprise. We have compared that to 21 different systems in the market. I don't have the time to show it to you. Okay, but we have elevated the research. Now we are using this jig, and this jig will allow us to have irrigation. We need to do this type of test with irrigation because the readings are completely different if you don't have irrigations. And moreover, I'm just giving you some preliminary results. It depends the temperature of the irrigation that the file will last longer in all of these tests. Okay, so we have compared 21 different systems versus way one goal. Okay, all these systems from different companies, even from their supply, we have compared, and we have way one goal. So I'm also happy to announce that way one goal came ahead of most of them except one system that we need to repeat the research on that particular system. That particular system, and the reason is that the handle was coming loose out of the file in the test. So we didn't have enough files to complete the test. It's not because of its metallurgy, it's because of manufacturing process. Okay, directions for use. And please, we need to develop instrumentation expertise through understanding. We need to understand how we use this instrument. And directions for use. Every single product has directions for use. Please don't go to the largest university in the world, YouTube. Okay, in YouTube you're going to find how to make a lemon pie, how to make even a bomb with fertilizing products, and you are going to see many ways that many other people are using Way One Gold, and they are explaining it. I have never put up anything in YouTube, but please, I kindly ask you to refer to the directions for use from the manufacturer to know how to use this instrument. Way One Gold, and every package has its own directions for use. Establish a straight line, coronal access to the canals. In the presence of a chelator, we need to explore those canals with a number 8, 10 file. Find out if those canals have are they patent. Okay, expand the glide path with a number 15, and then you can use a pro glider or path files. Sergio defines the glide path as the road map for files to follow. We need to show these files which way they are going to go. This is Way One Gold glider, which in the tip has a size of 15, in D1 17. The maximum file diameter in D8 is 0.41, and in D16 is less than 1 millimeters, 0.85. Okay. Though also this instrument has 12 variable tapers, and it has 16 millimeters in length, and comes 21, 25, and 31 millimeters in length, but it has 16 millimeters of an active part of the file. Also, this instrument in the cross section, it's the same cross section parallelogram as the Way One Gold, but it's a mini Way One Gold that will prevent really instrument failure. With this, it has 11, the head of the instrument, it's 11 millimeters, so we can put it in contriangles. And now I'm happy to inform you that very soon those 11 millimeters has been reduced, not only in the files, but also on the glider, Way One Gold glider, to 9 millimeters, that they are going to be coming very soon in the markets. We've been working very hard with Air Supply to accommodate that. It will give you the opportunity to put these instruments really in the back of the patient in those models. Then, and the ring is for single use only. As I said before, all the instruments has to be used one time only. This is the SEMs of the Way One Gold glider. Beautiful instrument. And this is the cross sections, as I said, parallelogram with 85 degrees angles. Okay, so let's talk about how are we going to use. It is of the utmost important. We need to start putting a rubber stop on the irrigation needle. That's a 30 gauge side vented irrigation needle. So every time that I teach, it doesn't matter undergraduates or PG students, we need to put a rubber stop. So we need to know exactly how far we are inside the root canal. Once we establish the working length, we are irrigating. Then we must irrigate the canal. No file comes inside the canal without irrigation. And after each single file comes out of the canal, that canal must be re-irrigated. We take a number 10 file, we explore the canal, we make sure that it has no obstructions, okay? And we see that the canal is patent. Every time that a file comes out of the canal, once again, that file has to be re-irrigated. That canal has to be re-irrigated. So on the working length, we are going to establish our working length. Now that I have known that my canal is patent, my canal is up to a number 10, I will place a number 15 file, preferably, to establish that working length. And I will put my apex locator, estimate the length through an x-ray. I would take my apex locator until I hear the sound that I'm at the place where I want to be. And remember, endodontics, requires a lot of attention to detail. Move the rubber stop to the reference point, remove the apex locator. Now we remove the instrument, and then we will record that length, okay? So we can really keep good records. We will record the length, and then what we need is to re-irrigate again. Remember, before any file goes inside the canal and when the file comes out, the canal must be re-irrigated. And then I will go with my little apical pressure, little by little, and when the rubber stop touches that reference point, that means that my pro glider, wave one gold glider, has really prepared the canal and ready for the wave one gold to receive inside the canal. We irrigate. This is wave one gold primary that you are going to see. Re-irrigate the canal. Advance 3 to 4 millimeters, no more than that. Even if you don't feel that resistance, remove the instrument from the canal. Observe the instrument, where those dentinal chips are coming. Clean the instrument. Observe the instrument again. Re-irrigate the canal, and you can see how it's coming through the coronal portion. It's the design of the file is augering that dentinal chip. Make sure that you have not blocked yourself with the same instrument that you have achieved your working length. Make sure that you have not blocked yourself. Re-irrigate again, and now you're ready for the second insertion of wave one gold. The second insertion here, what I did, it's a slow motion movie. Come on, movie, please. Here it is. Okay, so now it's in a slow motion, and you can see from the previous point another 3 to 4 millimeters we're going to be able to achieve. And the way that this instrument design is, you can see how it's augering. It's moving the dentinal chips towards the coronal portion. It's not going to pack dentinal debris. Look the efficiency in its cut. Look how much acrylic it's cutting. We observe the instrument. We realize that now we are almost in the middle portion of the canal. We clean the instrument and we observe the instrument for any imperfections, if it has occurred, unwinding and etc. We will irrigate the canal, verify that we have not blocked ourselves, and then we go for the final insertion. If we have a molar and we have as canals 10 millimeters in length, you need only like 3 insertions of the canal with the wave one gold to reach working length. This is in slow motion on purpose so you can see how the file cuts. And then once you have prepared the canal all the way to working length, that means that all those canals walls has been prepared. You don't need to go back and forth all the way to working length. We irrigate, we recapitulate again. In other words, we take the file that we have established working length with, we irrigate, and then now we are ready after a thorough and deep irrigation that we can go and start with. Oops, I have a problem here with. Let me just 1 second, please. I'm sorry. Apologize. When we're here, I apologize.
No problem.
So after that, then I use a core obturator technique. Once the canal has been cleaned, we now use the size verifier, where you can see that that convenience form has been really achieved, which allows me to a deep irrigation and a 3D root canal obturation. These are some of the cases. Please watch in that implant. This patient was referred to me because they said that he needs another implant because the fork is exposed through an endodontic problem, and the patient needs another implant. The patient decided to preserve this tooth. I'm just taking a lot of x-rays for you to see. So we finished the root canal. Look at this irrigation needle, wave one gold in the other canal, size verifiers, and this is how I finish the tooth in that section with core obturating with Godacor. Please look at this case. Then this is the day I finish, and this is the day that I start recalling the patient. And then I see that the molar has healed and the patient has lost the implant. So when I hear that implant lasts forever, I really doubt it. That patient lost that implant. This is a case from Carmen. Look how beautiful she finished with wave one gold, size verifiers. And also she uses core obturation techniques most of the time, Godacor. And this is how she finished the case. Jose Aranguren, look at the second molar here with those 3 curvatures. How beautiful he has done this case with Wave 1 Gold and Godacor. Rigoberto, very long tooth here. As you can see, these are working length, then Wave 1 Gold in one, reestablished working length in the distal. Size verifiers, this is the day that he finished, and here I think that we have some recalls. This is Lou Berman, an incredible endodontist, author, primary author right now on Pathways of the Pulp. This patient, look at the curvature. This is with Wave 1, not even with Wave 1 Gold, this is with Wave 1 and Godacor, the day that he finished. This is the day that he recalled the patients 2 years after. My question is, how are you going to do this with other instrument that has not been heat treated? Look at this case also from Lou. This bridge was from second molar to the second bicuspid, one piece to the other side. I know that I'm running 2 minutes over time, but this is it. And look at it. Wave 1 and Godacor. So basically, in a nutshell, very, very fast in an hour. I wish we could have more time. This is my email. If you have any questions, please don't hesitate to email me, whatever you need, any questions or whatever you need. And this is our website of the International Dental Institute for Ever Learning.
Great job, as always. Sergio, I'm going to let those people just jot that email down, and then I'm going to move us over to the question and answer section. So great job. Yeah, if you want to, are you back in the web room now? Have you closed out and stopped sharing so you can see?
I'm having the same trouble that I was not able to stop sharing. Oh, here it is.
Yeah. Can you see me?
Okay. Can you hear me?
Yeah, we hear you. Okay, good.
Yes.
So we will move to question and answer. We have lots of them. Let me feed them to you if you don't mind. And Sergio, if you could, I'm going to explain to people what's going on. I put a note to you on the far bottom right. If you could take a look at that, please, way off to the side of our web room. Could you read through that and just respond to that while I'm telling people how we're going to do this, okay? And then we'll get to some questions. Just let me know if you want to deal with that. So folks, what we're going to do, superb job, Sergio, as always. I'm going to start floating on questions sort of as they came in to the best of my ability. And I'm going to put them in this active question area so that everybody can kind of see what we're going to deal with. So let's start. I'm going to try my best, Sergio, to go sort of from beginning to end as the questions came. So that might have some relevance to maybe what part of the presentation you were in at the time that they came in. So very simple one here at first. Okay. What are active files? Maybe just explain that.
The active file. It depends on the edge of the instrument. If it has if it is like a profile, that's not an active file. The file is not cutting; it's scraping the dentin. If you don't have how can I say? Just escape my name. In other words, there are files that cut, there are files that scrape. If you have a file that is active, that it's cutting, it's better to do root canal than scraping the canal walls. Okay. Then the second question by
we don't list the names, but if you can deal with the
no. It says that there are articles showing micro K formation around apical third, X-ray, any and I don't understand. He's abbreviating so much that I don't understand the question. If he can rephrase the question below, I will appreciate. How to decide to go for then for the medication to use 4% of 6% taper? Okay. Always try to use the small taper. If I achieve my working length, for example, with a number in a distal canal with a number 25 file, of course I have to go to a larger file, but always try to start with a smaller tapers to preserve tooth structure. That will be better. Not only that, it's less mass of the instrument, will be able to perform better in curvatures. Okay, a Wave 1 Gold and a Pro Taper next, comparison article in. Okay.
I'm going to cut through. There was a few questions from this person. So it's referring to a 2018 study, Iranian Endodontic Journal, about these three files, potential microcacs in the bottom or something. So I wanted to send that to you in case you need to study that, or maybe you already know.
Okay. Okay. What I'm going to say about microcracks without talking about the different type of files. To have and I have complained to all of the journals of endodontics why they are accepting research that we cannot see the tooth before. There is from Brazil, Dr. De Deus, who has done incredible research that you previously micro CT the tooth, observe the tooth in its entirety, then perform root canal on them, micro CT for the second time, and see if it has a crack or not. And his conclusions were not even rotary and not even reciprocation will crack the tooth if you follow manufacturer's instructions. Okay, so once again, on research, we need to see the teeth before, on the teeth after. Okay, not because I cut the tooth in 6 millimeters and voila, there is a crack. Where the crack came from? How do we know if the crack was not there when they extracted the tooth? Okay.
Can you read? Do you mind if you read from my active question area just below our cameras?
Oh,
only because I'm sometimes combining some of the comments that came in. So yeah, this is from a university person. Yeah.
Okay. In case I don't have the XMAR Plus endomotor, what torque value is recommended for Way 1 Gold medium file? Okay, this is the issue. When you are using any rotary file in any motor, XMAR Plus or any motor, you can change the torque and you can change the speed. When you are using reciprocating movement, you cannot touch anything. You are kind of tight. We don't want anybody to change neither the speed, neither the torque, neither the degrees, clockwise and counterclockwise. It took Hassan Jared, I don't know how many months and how many, but I can show you photos of over 3,000 teeth that we did with a special motor to create 30, 150, the torque clockwise, the torque counterclockwise, and the speed. So it is embedded in that memory. Even if I give you the data, you are not going to be able to do that. That's why you must use a motor from the same company.
So okay. They were referencing, they have a university situation, of course, but what you're saying is really they need to get the appropriate motor to spin the correct way. Okay.
Yes, the correct way.
Question about, go ahead.
Should we apply the shaping principles in retreatment cases? No, we have to be very careful with retreatment cases. Number one, very careful in removing the gutta percha. Gutta percha has to be removed with hot instruments. Try not to use rotary instruments. There is one of my articles in the Journal of the American Dental Association, what happens when we use gauge clearance, how easy we are going to really weaken those two structures or we are going to perforate. So first we have to remove the gutta percha. The gutta percha has to be removed with heat. Be careful with the chemicals in the apical area because it will solve the gutta percha and the gutta percha will just go beyond that apical terminus. So it is a different. We can have another webinar whenever you want on cases of retreatment. That will be a good opportunity to talk about even how to instrument with new instruments and on the retreatment case. Okay. I have one more question regarding use alcohol as irrigant. It is effective at last irrigant in sequence of irrigation. No, it is not. What is the purpose of the article of the alcohol? Alcohol will kill bacteria? No. What are you going to use it to desiccate the tooth? No, I don't use it. I don't use it.
Okay. Let me bring another one on for you. Sorry. Let's see. Bring this one on here. And by the way, folks on mobile, I just noticed there the fourth icon down on your left is a document-looking button, and that will help you to see the active questions pod that I'm bringing on screen for Sergio. Okay, there you go.
How do you describe the relation between speed and torque in terms of safety? Okay, that's a very good question. Every file, when it's created, goes through the process of trial and error, okay? What they have done in rotary, and I remember Dr. Max Padden, who started it with Dr. Ben Johnson, when this file were able to cut better at what speed, okay? So every manufacturer has its own, I believe, and I hope they do, research on the speeds that they use and why they have achieved a conclusion that my files, it doesn't matter, the manufacturer has to be run at this speed or at this other speed in reciprocation. Okay, and in terms of the torque, is exactly the same. It depends on the file cross-section, in the helical angles, and how that file will engage into the canal dentin. If the file has very good edges, you require less torque to cut that dentin. If the file has a different cross-section, probably it will require more top really to cut that canal dentin. So what is the relationship? It depends exactly of what file, and I'm pretty sure that the manufacturers really have achieved their conclusions according to research. Why did they change the original initial reciprocation movement? No, it has not been changed. There has never been changed. Since day number one, when Way 1 came into the market in 2010, the file has always been moved 30 degrees clockwise, 150 degrees counterclockwise. It has never been changed.
At least in the Wave 1 system.
I'm talking about Way 1. I cannot talk about the other systems.
Yep.
How did you decide master apical size? What is going to bring you which Way 1 gold I should use? If I get if I have a tooth that to get to working length, I have used 7 number 6 files, 4 number 8 files, 3 number 10 files, is telling me that the lumen of that canal is very, very tight. I have to observe the anatomy or try to imagine the anatomy with at least the 2 x-rays that I have taken before treatment. Now, if it has been so tight, I will acquire only a small Way 1 gold. If I'm able to place a number 10 file tight inside the root canal, I know that I have enough room to work with a primary, which is a 25. If I establish my working length on a distal root and I put a number 20, it's loose, 25 is loose, and number 35 is start getting tight, I will use the 35, the medium. In a palatal canal, I place a number 40, or in a central, okay, I place a number 40 and starts feeling a little tight, then I will use the large one. That will dictate which file I will use. But in terms of the master apical file, I will use only one, the one that I started. I will not start with a small, then enlarge the canal to a primary, and then keep enlarging to a medium. There is no reason for it, if I can achieve a deep irrigation to allow me for a 3D obturation. How to avoid the sucking effect of the Way 1 gold into the canal to avoid apical transportation. And it was a strong tendency for this sucking effect as soon as the beyond the curvature. No, okay, I understand your question. You are going to feel that the file is pulling you down at the very entrance of the canal only. After that, the only thing is, by the contrary, you need to start advancing the file. When the file goes through curvature, and once again, we have to start measuring with our eyes those 3 millimeters of advancement, just little by little. It's like kiss and goodbye. The file will engage, remove, engage, remove, engage, remove, engage, remove, and that's how you achieve those 3 to 4 millimeters of advancement. Remove the file, irrigate, take the number 10 file that you have established your working length, make sure that you have not blocked yourself, remove the file, irrigate again, and then you go again with Way 1 gold inside the canal. So that effect of soaking is just controlled by your hand, and it only happens, at least in my hands, at the very entrance of the canal, the very first time to really get into the coronal aspect of the tooth. That's all.
And as I put this next one up, I just want to thank everyone for sending these questions. It's, usually someone's question is probably thought by many other people. So when we share these and we get the answers from Sergio, I think it's helping many. But it also is good for us when we think about our future webinars, probably good for Sergio to see what people are questioning so that he can think about future presentations. So do appreciate these. Go ahead, Sergio.
Single visit. Spend in a single visit when we'll dry the canal. What would you suggest? Okay. I was taught with the philosophy, single appointment only, one appointment only. I can start quoting articles of you are going to dress the canal with calcium hydroxide and the effects of calcium hydroxide, on and on and on. And how do you remove the calcium hydroxide in the next visit really to achieve a good interface between canal wall, cement, and good aperture? I always do root canals in one appointment. There are 2 circumstances that I cannot do root canal in one appointment. Number 1, when I cannot dry the canal. Not fully dry, but dry enough the canal that my cement will set. And then in the past, when I used to use rotary, if I would separate an instrument, I will not go after the instrument in the same appointment because I'm so upset that I will be removing too much to structure. I will put it for another appointment. Otherwise, and I teach always root canal therapy in single appointment. But to make here also another a point, when you are preparing the canals, and I said this in a very nice way. Unfortunately, with wave one goal is so fast, you get to working and so fast, now you have the time to irrigate. You give the patient an hour appointment, but the preparation of the canal, the cleaning and shaping goes so fast that now you have all that time to spend in irrigation. Do it. I have some colleagues that said, Sergio, with your files, I can see 2 patients in an hour. I turned to them, I said, you know something? You are defeating the purpose of the file. The file is to achieve a good preparation. Yes, unfortunately, it's in a very short time, but now you have all the time in the world to irrigate that canal. Okay?
Good.
Next.
Uh-huh.
A use of single cone for obturation, justified. Or should we prepare canals with larger taper and also some accessory cones? Also a minimal taper tip combination for proper disinfection of molars. Okay. How much time do I have? Single cone. Unfortunately, I will love to show you, or I will love, email me, you have my email, I will send you micro CTs photos, what happened with single cone, all the voids between the gutta percha, the cement, and the canal walls. Okay, to me, that's not an obturation. We don't see those with our eyes on an x-ray because the section with the micro CTs are approximately 6 microns, or with the nano CT, yes, that goes up to a micron. And you see all these voids, which I believe are important, number one. Number two, should we prepare to a larger to use accessories? No. You can use a number small way one goal, and then you have the cones, small gutta percha points, way one goal, or if you use carrier base, which is a warm obturation technique, okay, which to me is the best way of obturating 3-dimensionally because of the hydraulic pressure that material is being put inside the canal, that it will really fill the canal 3-dimensionally. Now, in terms of molars, you can prepare a number 25 without any problem in most of the initial goods, okay? It depends the anatomy, depends of many other things, but a primary, I would say 95% of all my cases are with 115 primary, which is a 25-07 taper in the very first 3 millimeters. But if I see that the canal is tight, I will use a smaller one. If I see that my palatal canal, I use a 45, I use the large one, okay? But it will not prevent anything of my disinfection. The most important step in root canal therapy is disinfection. That's the key of success in root canal therapy. Thanks for the great webinar. I know that Wave 1 Gold is a single-use file, but we are in the third world and costly and hard to get hands on a file, so I start more on the patient. What are the thought about that? Okay. I wish if one day, moreover, email me, please. Kuttler, @idifl.com, and I will send you a PDF of research that we have done. What happened to the instrument when you use it once, twice, 3, up to 9 times? For 2 reasons. How even use it and then go through the right process of sterilization, which means we brush it with a metal brush, we go through the ultrasonic bath, and then we put it into the sterilizer. And then we open the instrument, we photograph inside the scanning and electron microscope in the same place, and you can see that many of that bacteria cannot be removed. Chunks of dentinal chips are stuck into the instrument. You cannot see that with your loops. You cannot see that with an operated microscope. You need a scanning electron microscope to do that, okay? And then you will see that the file is not clean. But you're going to say to me, yeah, Sergio, but those are dead microorganisms. Well, that's it. If you want to use those in your own mouth, I don't have a quarrel. I don't want those files in my mouth, number one. Number two, you can see the age of the instrument, how the instrument is deteriorating every time that we use it and use it and use it, to the point that I can show you instrument that after single use, after 1 molar, You see the edges and then you say, oh my God, how come this instrument has not separated? But you don't see those with your eyes. Single use only. And the last part with that, if we tell the patient, listen, this root canal is going to cost you X amount of money, wherever you are. And I have used this file. Mary, how many times I have used this file? 3 times. And then you offer to the patient, these are brand new, but the root canal is going to cost you more because this file costs this much. I want to see if the patient is going to choose use files. I guarantee you the patient is going to say, no, 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 I want new files. Okay? How to proceed?
Okay. On this one, Sergio, I wonder if you expand the severely curved root canals. I mean, I think that's a very technical, specific thing. But, a lot of times we always get asked, okay, on all these file systems, is this one especially made for these kind of teeth, or this part of the mouth, or excels here but doesn't do well here? That's usually the question. Can you speak a little bit not only to curved canals, but in fact, what Wave 1 Gold is perhaps best at, or something?
I have shown only a few of the hundreds of cases that we have with severely curved roots. Once you start getting with the glide path, with the Wave 1 Gold glider, that truly is going to go through that. And once you start, for example, with the primary, and you get to that curvature and you cannot go through, stop. Do not continue. Once you start getting into that curvature, go to the smaller Wave 1 Gold. So you go to a number 20, little by little. What you're doing, it's enlarging that glide path. So from the Wave 1 Gold glider to a small Wave 1 Gold, which is a 20, and then I finish with the 25 because I started with the 25. Or if you want to finish it with the 20 small instrument and you are able to irrigate really deeply and really fill these canals very well, I don't have a quarrel with that. But don't push the file. Wave 1 Gold or any other file, when you are getting into those curvatures, don't push, go to a smaller instrument. Smaller instrument, smaller taper. And then once you achieve that working length with that smaller instrument, smaller taper, if you want to go to the next one, go ahead. But very, very, very careful. That's the only solution that I can say. Is extrusion of endodontic sealer beyond dip is good or bad? It depends the type of cement that you're using. It is forgot this name. Okay, Spamberg, Langeland, and Safavi, in conjunction with this Brazilian guy, Eliseo Pascoal, oral surgery, oral medicine, and oral pathology, around October 1982. They published a great article that they put in behind the lab rats, and they followed those right for years, and they used several in those days, several cements. Every time that you use a cement that has ZOE, eugenol will create an irritation. It could be a chronic irritation, could be a simple irritation, it could be symptomatic, asymptomatic. Since my days, even when I was in dental school, probably the person who asked this question you were not even born, okay? Even in my days, I use a cement without eugenol. In this case, it's AH+. In many countries, it's called Ribbon, it's called many other names, but it's the same cement, which is AH, which in the past it used to be AH26, but now it's AH+, as I said, Ribbon, and it has different names, but it's a resin base. It's not used with eugenol. I forgot. With eugenol. So avoid eugenol. That would be better. If it is bad, listen, the PDL is not a garbage collector. They don't like to have any foreign material. So let's try to avoid that. But we have some filling techniques that they are inherent in their technique, that expulsion of that puff of cement, okay? Or sometimes we go with gutta percha. We have to be very careful. We have to be very cognizant where is that apical area and to respect that apical area, okay?
Several irrigant and irrigation questions I've just kind of lumped in here.
Okay, which is the best final irrigant until the SIAC doesn't bring the one at the end of the year of theirs? Right now, what we have is sodium hypochlorite and then EDTA, just to remove that smear layer. And then you remove that EDTA with as a final irrigant with sodium hypochlorite at 6%. Okay. Now, if I tell you that yes, you can use QMix, but in many countries you don't have QMix, okay? So there are many other products that it's not available, but I know that right now in your countries what you have available, it's sodium hypochlorite, and then it is to remove this meal layer, okay? But I don't use chlorhexidine, I don't use nothing of that. So as a final ring is my sodium hypochlorite. I will remove my smear layer, okay? And then sodium hypochlorite again, and then dry the canals and clean the canals in that appointment, okay? Which of the final, what is the urinary protocol in infected necrotic? In infected necrotic teeth, like any other teeth, it's exactly the same. It's exactly the same. I don't change to medications, this and that. It's because of the study have shown that there is no, it is the same success rate, one appointment versus multiple appointments. Is less pain in one appointment than multiple appointments because you re-entry. And for 1 second, please, for 1 second, all of you, forget about dentistry. Forget about dentistry, forget about science. Let's talk about economics. How much does it cost you, that hour, that patient in the same chair, using all your disposables? It's costing you more, okay? So once again, single appointment only. Does Way 1 Goal and True Anatomy files share the same regressive? No. The concept, yes, of regressive, yes, not to prepare, yes, but there are two different files. There are two different files. One is rotary, which is very good True Anatomy, and it's off-center, okay? But it has the same concept of regressive taper, yes. Rotary file pulls debris outwards. Rotary files outwards, but reciprocal files partly push debris. Dr. Sergio, our experience of incidence of post-operative pain using Way 1 Goal, which is a reciprocating. So if I understood correctly, you have had more pain with reciprocating than non-reciprocating. Please email me. I will send you. This Turkish group did an incredible research that the re-push outside is operator dependent. It's operator dependent. It's not because of the file. And not only that, there is another excellent journal, International Journal of Endodontics by the Deus group in Brazil, that they push less debris with reciprocation rather than multiple rotary systems. So I will be very happy to send you those articles. By far, we have not experienced pain with reciprocation. Or using EDTA paste, do you recommend using until the master file or create using or cease use? Okay, EDTA in paste, you're assuming it's like product. You only use this type of files just when you go inside the canal for the very first time because of the lumen of the canal. Sodium hypochlorite will not go down, so you need to have something between the file and the canal. And yes, I will use EDTA in the beginning. Once I'm able to start irrigating the canal, it's done. I will use EDTA as a liquid at the very end as a final irrigation to remove this mid layer and remove that EDTA with sodium hypochlorite, dry the canal, and then fill the canal. But the paste, just in the beginning, never, not continuously.
I might comment as you. Oh, sorry.
There are even research from Dr. Ovi Peters that actually you will prevent the file to be so efficient like True Anatomy if you use this along the way like many other people are using.
I make a comment. Let me make a comment quickly here. I've put your email address a few times down in the chat pod below. So you've offered that a few times. So people, if you're looking for that to touch base with Sergio later, please find that there and take him up on that. Yep. And if you don't mind that bottom chat pod about webinar comments, as we're dealing with questions and answers, we do appreciate your feedback just on the webinar, presenter, topic, future topics, the experience you had. Just it helps me go back and frame up how we do more of these. So anyway, go ahead, Sergio, with the questions.
How do you instrument fracture inside the canal, which is not retrievable? Okay.
Avoid fracture. Work on your technique, right?
No. First of all, you have to be very careful with the words that you're choosing. Legally, in the United States of America and in many other countries, the word fracture should never, ever be in your chart, in your medical record. Fracture legally means intent. You intended, you on purpose, you fracture that instrument. The word is separation. The instrument separated. Why? Whatever reason that you want to put. Never use the word fracture. That's a key. Number two, regarding your question, I can show you statistics of Nova Southeastern University. I can show you statistics of several universities. Nova has been using weight one since 2011. There are no separations on the clinic floor. Obviously, single-use instrument, okay, as the manufacturing instruction says, okay, zero on the clinic. But there are some instrument separation on the preclinical, on the technique lab, when the students are teaching, they are learning how to do root canals in extracted teeth. Why? Because they use the instrument several times. That's the only reason. If the students at Nova Southeastern University or any other place, they will use an instrument only one time only, there will not even be separations in the clinic, in the preclinical. Now, if you have a separation, how do I deal with it? We need to stage down to remove the instrument. Dr. Teraguchi has come up with a new kit. I mean, it's very good, but whatever reason, you need ultrasonics, you need a microscope. You cannot remove an instrument that you don't see. Sometimes they are beyond the curvature. What are you going to do? You need to try to bypass it. We can go on and on and on and on regarding how to deal with this, which it will require another hour even to show you cases, not only of separated instruments. What do you do with broken screws from implant? Okay, which is sometimes even more difficult to remove without touching the screws of the bolt. So, in other words, it's very difficult to separate an instrument. And once again, that's the occasion that I will not finish on the first appointment, because I will be so upset that happened that I would like to go with the instrument immediately. And that's when we start removing a lot of tooth structure. Oh, we removed the instrument. But you look at the case and you said, oh my God, as soon as that tooth is going to get into occlusal forces, for how long is going to last? How long is going to survive that tooth? Separated instrument requires, I truly believe, a different webinar that we can spend as an hour instead of only a couple of minutes just to answer this.
That's a good point. That and also retreatment, we heard several people say, so it's probably worth looking at.
Yes, we're looking at.
I think we may be getting some repeat questions here, but just in case, I'll put them up on screen.
I have very good research done, very good scientific research done by several other doctors that reciprocation extrude less than rotary. Okay. In retreatment cases, do you recommend single visit as well? And yes, single visit except one condition: silver points. If you are removing a silver point and you are successful without separation of that silver point because of corrosion, and if you finish and cleaning the canal, do not fill in the same appointment. That's the only circumstances, the only instance that I will not fill in the same appointment. Otherwise, I will, no problem. I don't see a problem. Those concerning final canal retreatment concerns visiting as well, and concerning the final canal diameter. It's clear that you go for prevention of dentin thickness within the root canal about the selection of the proper size of way one. Once again, the proper size of way one is related to the anatomy, okay? Once again, to remove that gutta percha, you don't use instrument, you use heat, okay? And then if you want, you use Hedstrom files, okay, little by little. But if the canal has been already prepared to a number 40, am I going to use a small one? No. Am I going to use the primary? No. Am I going to use the middle one? The middle? No. I'm going to use the large one, which is a 45, just trying to remove the rest of that gutta percha that probably remains in the dentinal tubules, remove that cement, try to clean better, irrigate better, and fill the canal again. But it's not that the size of my retreatment is correlated with the file. What about if after I remove the gutta percha, I see that the canal is a number 50? I cannot use way one gold. I can't. I have to use another system that it will have larger instruments. Okay, like ProTaper. I will use ProTaper Gold. Okay, and F5. Okay. Did I move that?
No, I moved it, and we've gotten to the end, I think, of all the questions we've received so far. So I'm going to go ahead and let us wrap up. We're we're not religious about the time, but it's 10:30, and I think that's good. We've taken enough of your time as well. You're
No,
great. You're great for offering your email address, so I offer that to everybody once again. If you have some specific topics, I do appreciate on this comments below me. If you don't mind just sending in sort of an informal evaluation, you'll receive a follow-up email, everyone, that will have the recording link of this webinar, an online survey you can do about the experience. And then also I'm going to throw in some actual technique videos. I know Sergio told you to stay off of YouTube, so I'll send everyone some of Sergio's Wave 1 Gold technique videos that we do approve and endorse, and I'll make sure those come in the email to everyone too. So I do appreciate the comments coming in, but also, take advantage to maybe throw in some topics you'd like for the future. We've got some other Dentsply Sirona people watching and listening in, and they're making notes about how we can frame these up to be of most use to everyone that we try to reach. So don't hesitate to throw them in. We heard retreatment and broken instruments quite a bit here, and also maybe detail about the IQ motor that Sergio said he could talk for hours about. So we're getting ideas. We don't want to do these things for us. We want to do them for you. So please send in your requested topics. Go ahead, Sergio.
and there is Dr. Janina. She says if we can have webinars on retreatments, pulpotomy, patency concept. You have to remember in 1 hour, and I know that I went even beyond that, and trust me, I usually take 4 or 5 hours just to talk about root canal preparation from A to Z. Condense this in an hour, it's it's a lot.
Yeah.
It's a, but definitely, we will speak with the powers to be at Dentsply Sirona, and we would love to have some other topics in the seminar for you to attend, without any doubt.
Absolutely. So that feedback is excellent. So we can make sure we're doing things that are the most useful to all of you. We've had almost everyone stay on. So Sergio, I'm not surprised. You're very attention getting and engaging. So, and always full of great information. So I know everyone got a lot out of this. We appreciate your time, Sergio. Just so everyone knows, Sergio will probably dismiss, of course, or he can stay if he likes, but I am going to shut off the audio. I'll leave the room open so you can continue to send in some comments or topics. For a while, maybe 5 or 10 minutes. Sergio, you go or stay as you need to, and same for everyone.
I need to ask you also of your forgiveness. Sometimes to answer your emails, it takes me a couple of days because I get a lot of them every day from lectures, webinars, courses, and even some work that I have to do. So, but usually I answer to all of them. So be patient with me, okay?
Super.
And if they need the articles where I base my this topic of Wave 1 Gold, it's approximately 300 articles that I will be very happy to upload you and send you the link for you to download it. But one condition, you have only 1 week to do that. If you have not downloaded in 1 week, my computer people here will just say, we are overloading the servers. You know how is that, John? And then your name will be deleted. So, but if you need the articles where I base all these scientific criteria, by all means, email me and I will upload all the 300 articles for you to download. Okay?
Super. Well, like I said, we'll wrap up. Thank you, Sergio. Yep, we will close up. Yep, okay. I'll keep the web room open just for chats and I'll watch those. Thank you very much, Sergio.
See you soon, my friends. Thank you.
Okay.